Hello, everybody. This is Dr. Andrews. I'm delivering this lecture, Biomechanics of Pes Cavus. This is a pretty broad topic, and I was able to kind of whittle it down. I probably cut out probably about 30% of the total number of slides I have, but this is a very unique topic, particularly in my realm of residency education, because this topic loves to show up on board exams, particularly ABFAS exams and mass. So we generally tend to see a lot of questions regarding Pes Cavus and associated pathologies with it. So I'll just jump right in. I'm a frequent MPMA lecturer, of course. I've been involved in residency education my entire professional career since I finished residency myself at the current program, where I'm currently the program director. I've got a couple offices in Macomb and Oakland County. I consider myself to be a surgical biomechanics enthusiast. If anything, that just means I enjoy a metaphorical bludgeoning of residents with regards to academic minutia in the terms of biomechanics. I do have consulting agreements with a couple vendors. However, none of those products are featured in this presentation, so I have no conflict of interest to declare. And as I'm recording this, we are still a couple days short of the Super Bowl here. I just wanted to make note that just about every single year that I bet on the Super Bowl, I lose. Going back to the first bet that I can remember making, which was on the 1988 Cincinnati Bengals, where I bet against them and I lost a can of soda to one of my siblings. By the time we get to the MPMA conference, the Super Bowl will be over, so feel free to ridicule me with regards to my terrible sports gambling habits. So here's our brief outline for today. We're going to talk about Pes Cavus and sort of the etiologies of it, and primarily just biomechanical considerations. We're also going to discuss a little bit of a continuum of treatment. I did have some regards to surgical management of biomechanics here, but I decided to omit that almost entirely. I think that's probably way too much for this short of a time frame. So we'll talk a little bit about conservative management, about orthotics and bracing as appropriate, even though I know within this lecture track there is some discussion on those modalities as well. So we know what Pes Cavus is. It's a high arched foot, however you want to describe it. We can discuss anterior cavus, posterior cavus, and then whether it's in the context of the syndromic condition, whether it's isolated, whether it's unilateral. But the difficult thing about Pes Cavus is really just what it does to your feet long term, and the adaptive changes that occur not only within the feet but also just the entire lower extremity throughout the kinetic chain. So in general, with Pes Cavus, we have much less compensation than Pes planus, and I'll show you a little bit about why that is. So people with a cavus foot, they tend to distribute force a lot differently than a rectus foot structure. And the foot functions in a much more rigid fashion, so you're transferring a lot of that stress up the kinetic chain, so you do end up having some problems with the knee, particularly the medial compartment of the knee, and then possibly rotational issues with the hip and low back also. Now keep in mind that Pes Cavus can be a manifestation of other things as well, such as scoliosis or congenital hip dysplasias, things like that. So sometimes, it's like a chicken or the egg thing. Do you have Pes Cavus as a result of another process, or do you have other pathologies because you're dealing with a cavus issue? It is frequently associated with neuromuscular or spinal conditions, particularly conditions like the Charcot-Marie tooth, which is a relatively common one that we see, and I've got a handful of CMT patients in our practice. And you're also more likely to develop structural changes to the foot, which generally need to be managed a little bit more aggressively, just because we really don't compensate for it as well. So the lack of compensation for a cavus foot and being able to, say pronate through your subtalar joint to be able to make some of those mechanical adjustments to your gait pattern, with cavus that really is not a thing. So these problems tend to be more surgical in nature sometimes. So particular etiologies, hereditary motor sensory neuropathies. So HMSN type 1A is classical Charcot-Marie tooth. This is more of a perineal palsy as opposed to just being a true motor sensory neuropathy. Dejerine-Sotas disease is another one that I have seen in practice. These are things that will cause selective loss, particularly the anterior and lateral compartments of the leg, related to perineal nerve palsy. They also affect the ulnar nerve, disproportionately the upper extremity as well. So oftentimes you'll see hand and wrist abnormalities in association with CMT. CMT can be relatively mild, or it can be an absolutely crippling deformity. I had a great presentation that, or a case study I was going to toss on here as well with regards to a CMT patient, but one of our first-year residents is actually presenting it at the abstract conference on Saturday. So I've omitted that here, but it was a fabulous outcome that we had with regards to a CMT patient. Secondary neurologic lesions, particularly spinal cord pathologies, transverse myelitis, syringomyelia, multiple sclerosis. These are relatively common as well, that will cause kind of later acquired cavus conditions, if you will. And spina bifida, which is, I think, probably underdiagnosed in a lot of these instances as well. So you can have spina bifida occulta, and if you showed me a child that had that was a toe walker, or that had a pretty significant cavus foot, that'd be the very first place I would look. I would order some lumbar spine films and try to elucidate better, what the etiology of the pathology is as well. And also some genetic things as well. These are more gait abnormality or gait instability problems, like Friedreich's ataxia, which I've never seen, and I don't know that anybody has ever seen, but it loves to show up on board exams. So we always try to cover some of these ataxic gait type problems. And then it is also a component of clubfoot as well. So we do sort of summarily mention the cavus aspect, but however, clubfoot is largely a problem that's a multifactorial deformity, with the apex of deformity being really the talus. So these patients will have a smaller dysmorphic talus that can somewhat be contributory, but really the equinus component and the muscle adaptations as a result are generally what led to the equinovarus or the cavus type deformities in this patient population. But that is, of course, a multiplanar deformity, whereas Pes cavus itself tends to be primarily just a sagittal plane deformity. Conditions that are associated with it. Midfoot arthritis is a big one. So you see people with that big cavus foot type, they have a lot of midfoot spurring. A lot of that has to do with the angle that those metatarsals and the tarsometatarsal joints are undergoing when they transfer weight during gait. And again, this is because the foot is functioning in a more rigid pattern. We do see a lot of midfoot arthritis, and of course pathologies associated with that. And I've got a separate slide with regards to this topic. Forefoot pathologies for sure, not only due to the angular deformity of the metatarsophalangeal joints, but also things like nerve impingements, neuromas, plantar plate issues, flexion deformity of the hallux, sesamoiditis, which are largely just contact pressure issues, really akin to patients that wear heels all the time. I stopped wearing heels several years ago, so it really hasn't been a thing for me. But these are very, very common things that we do see, particularly in cavus foot. And sometimes this is the initial manifestation. This is why people come into your office in the first place. Achilles tendonitis and bursitis are pretty frequently common as well. That has to do with a calcaneal inclination angle of the heel. And in the context of Haglund's deformity as well, you have a lot of retrocalcaneal pressure against that Achilles tendon when you're walking, and bursitis is relatively common. Generally managed a little bit more aggressively than just run-of-the-mill retrocalcaneal bursitis. Ankle impingement as well, just associated with the pseudo-equinus component, or also just the dorsal midfoot pressure. And then ankle instability, especially in the context of a varus heel. And then perineal tendinopathy as well, which I think is probably under-mentioned with regards to cavus. And some of this has to do with direct physical impingement from like the perineal tubercle against a varus heel. It's in the context of ankle instability. And you can have, of course, perineal pathology just related to spasming or other types of musculoskeletal issues associated with plantar flex first ray or really just overuse of these tendons. And then, of course, when you have selective loss of the perineal, such as in like a neuromuscular condition as well, that can oftentimes play into it because you've got forces that are pulling in other directions. And sometimes the perineal tendons become significant when you're considering procedures like tendon transfers or even fusion procedures, just to make sure that the foot is tethered into an appropriate position. So we'll take a step back and kind of look a little bit more at some of the pedagogical approach to Pes cavus. This is, of course, pretty straightforward. You have a pretty significant increase in calcaneal inclination. You do see that bullet hole sinus tarsi thing that they teach us about in school. At first glance, you may look at an x-ray like this and say, hey, this looks like almost like the foot's rotated or the patient's pulling their first ray off the ground. But if you really see that those longitudinal axes of the first metatarsal and the talus are really, significantly divergent. And this is, like I said, primarily a sagittal plane deformity. So that contact pressure against the ground, particularly the first metatarsal here, this is where you see a lot of additional weight-bearing stress to those areas that can really cause a lot of pathologic issues in association with cavus. So that's really I guess, kind of the crux of the argument. This is called essentially Cotton's tripod. When you have a really high arched foot, your foot functions more like a tripod, where you tend to put most of your weight under the first metatarsal head, the heel, and the lateral portion of the foot, usually the fourth or fifth metatarsal head, kind of depending on patient-specific factors, and/or do they have any component of forefoot varus or valgus. So the real culprit here is that you've got a much higher force per unit area just because you have less surface contact against the ground. And what does that look like on a gait map? And it looks something like this. So this picture on the left is essentially a relatively rigid cavus foot, where you've got very little contact pressure associated with the midfoot region, and most of the contact pressure is associated with the heel. And in this case, it appears to be like the first metatarsal hallux, and then that's the third or fourth metatarsal, and the fifth as well, as opposed to a mapping of plantar contact pressure of a rectus foot, where the force is a little bit more uniformly dispersed, and we don't see a lot of these areas of real, red, angry-looking high force per unit area. Another way to look at this as well is just with a different type of heat map. And again, you see people with a high arch that tend to have a lot greater forefoot contact pressure, which can be oftentimes very contributory to a lot of pathology, not only of the forefoot, but also of the rear foot and ankle as well. So, of course, we remember these root biomechanics diagrams here as well. Why does this happen? Why does the foot become so rigid? It's because it's functionally maximally supinated. We know that as we go through the gait cycle, in a normal foot, you're going to initially pronate your subtalar joint and then supinate your subtalar joint with heel off to turn the foot into more of a rigid lever in order to propulse yourself forward. The problem with cavus is you've got that axis, which is almost perpendicular, the subtalar joint axis, so you're basically stuck in a maximally supinated position. When you have significant pronation, you can unlock your mid-tarsal joint to be able to pull your first ray down to the ground, and this is what's called Elftman's theory, to be able to stabilize yourself during gait. But the problem is that's really not a thing within cavus, just because your foot functions maximally supinated. You maintain more of a rigid foot structure, and you lose a lot of that shock absorption, if you will, of the rear foot apparatus. So you do have a decrease in force distribution of the kinetic chain. So what that essentially means is that you're not going through a range of motion with your talonavicular joint. You're not utilizing your spring ligament for additional support and propulsion of the rear foot in gait. So this lack of a shock absorption with the foot is oftentimes what leads to proximal pathologies such as knee or hip issues, or even low back as well. So with the foot functioning in a much more rigid position, we just don't distribute that force in an appropriate manner, and this is oftentimes what leads to pathologic gait changes, or even compensatory things that can occur, like widening of the base of gait to be able to stabilize your foot. This is going a little old school here. Our retired partner in our practice, Dr. Walter Coleman, who was in practice for nearly 50 years in Southeast Michigan. I used to say the Coleman block test was something that he invented back in the early 19th century. This is a good modality, and it's definitely underutilized, because I ask our residents all the time, the Coleman block test is going to show up on your board exam. But so how do you do it? What is the rationale behind it? How is the Coleman block test beneficial? And so I implore all of you, if you got a patient with a cavus foot, do this test. You'd be surprised what you see. You'll be surprised, that the heel will or will not invert. So grab that Dorland's medical dictionary, that big red book that's hasn't been opened since your first year of podiatry school, and then have the patient step on it and then drop their first ray off and see if the heel inverts or not, just to see if you have any kind of compensatory changes within the rear foot. Obviously, if the rear foot fails to fall out of varus, then you definitely have a structural deformity involving the rear foot. And sometimes that will change your management. So this is part of your physical exam, as well as watching these patients walk and do manual muscle testing and things like that, because you really need to discern how much of your rear foot is involved, because that's going to drive everything with regards to how aggressively you treat this, and then what your treatment options really are. So your treatments are really going to be based upon the flexibility of the rear foot. So what type of orthotic are you going to do? If you've got somebody who's got a rigid, supinated, or cavus foot, oftentimes they're going to do better with like a softer orthotic, that with something that's just like a multi-layer EVA as opposed to something like it's a thermoplastic, like polypropylene or something like that. So it's oftentimes going to really determine what you're using as far as materials, and then how aggressive you want to be with an arch fill. It will also determine things like types of procedures as well. Is this patient an appropriate candidate for a Dwyer osteotomy versus a subtalar and TN fusion or triple arthrodesis? So it definitely significantly drives your surgical decision making, as well as what your appropriate treatment options are for these patients. And then, of course, long-term expectations are always appropriate too. A lot of patients that have a cavus foot that come into our office, I'll tell them, hey, this is, you're probably going to live in orthotics, and people with a high arch foot, they tend to have just a lot bigger problems long term. And if you're, having difficulty walking, we'll talk. We've got a lot of different things that we can do from a palliative standpoint, but then also, from a surgical standpoint, should it become necessary. But that being said, for the most part, I really don't view cavus as a surgical problem. Definitely not, at least primarily, and it should be, of course, the last resort, as most surgery should be. So I'll talk a little bit about some of these additional, focal pathologies associated with cavus, and especially some of the bigger ones that we see. Midfoot arthritis is super common. I do a lot of injections for midfoot arthritis. People do great with it, and I've got probably a group of maybe 12 to 15 patients that just they just get this rear foot arthritis that will just flare on them periodically, or they'll have some dorsal nerve impingement associated with it. We just do injections periodically, and they're fine. I see them maybe every 4 or 5 months or so, sometimes more frequently than that. But why does this happen? So I drew a couple force vectors on this diagram in the top here, and you can see the angular relationship of a cavus foot versus a relatively rectus foot, where you've got plantar flexion of your first ray. So the force that travels through the tarsometatarsal joint is not an axial force, but it becomes a lot more oblique in the context of cavus, because you do have that higher forefoot contact pressure. So you get a lot of jamming of the midfoot that occurs. You can get some heterotopic bone that will cause spurring in that area, which is probably one of the most common manifestations of problems with Pes Cavus. But oftentimes these things are just a mechanical impingement. They're a physical irritant. They will cause capsulitis, those midfoot joints, with inflammation. You can get secondary dorsal nerve pathology that occurs. We get some pinching that goes through there, and that's a quite common thing that we do see. In our practice, this is probably the most common manifestation of high arch foot that I see, where people will get this dorsal pathology. Extensor substitution as well. So you'll develop contractures of the digits, and these generally need to be managed a lot more aggressively than the flexor stabilization type hammer toes that we tend to see more in pronatory type foot deformities. This is a swing phase pathology where you have your dorsal extensors that are just overpowering your intrinsics. So or they're working a lot harder, and it tends to be a progressive deformity as well, particularly in the context of things like Charcot-Marie-Tooth and other neurologic problems that are progressive in origin, with the exception of course, typically stroke and cerebral palsy, which tend to be kind of regressive. They do tend to improve over time, particularly with aggressive therapy. When I say aggressive correction with these, part of the problem is the contracture at the metatarsophalangeal joint itself. So the metatarsals are at a much more oblique angle with the ground, and the toes are probably not going to be ever generally straight. And I'm not a big fan of using toe implants anyway. We'll use K-wires. But you need to be pretty aggressive about these. You oftentimes will need to do a dorsal extensor lengthening, a dorsal extensor hood release. So really go through the steps of your sequential hammer toe release. And generally, you'll need to be pretty aggressive and possibly overcorrect these. So what I'll do with these is I'll do a dorsal extensor lengthening, and then we'll pin them in a bit of plantar flexion as well. And then generally, if the great toe is involved, I really don't even bother with any soft tissue with the great toe. I'll just do an IPJ arthrodesis. But these generally need to be managed a lot more aggressively than other etiologies of hammer toe types. Perineal pathology is also pretty common. Impingement, particularly against the perineal tubercle, and this is a X-ray and CT scan that shows a prominent perineal tubercle. This can be especially important in the context of calcaneal fractures. So if you have sequela of a calcaneal fracture, we have one of those lateral wall blowouts, whether or not it was fixed, even if you did have an ORIF, or some sort of pinning or fixation, oftentimes that lateral wall of the calcaneus becomes a significant problem, which is why one of the reasons why when we teach particularly rear foot trauma, the cardinal rule is thou shalt not varus. And this is one of the reasons why, because you get a lot of irritation against the perineal tendons from that perineal tubercle directly, and it can cause surface fraying, and you can actually have physical tears in association with that. Um, So perineal tears are also common, oftentimes in the context of inversion sprains or inversion injuries. We do see a lot of perineal tears. It's oftentimes really just an incidental finding on an MRI. We'll send someone for an MRI for ankle impingement or instability, or looking for OCDs, things like that, and then we'll see a perineal tear. Well, sometimes those don't even need to be fixed unless it's something that's specifically causing the patient directly discomfort. And then of course perineal spasm is a thing as well, particularly if you have a varus heel. Your peroneus longus is working a little bit overtime to try to bring your first ray back to the ground, which can be really a manifestation of cavus foot. And that if those perineal tendons are working overtime, you can have some gait instability associated with spasm or other musculoskeletal pathologies like cramps within the legs and things like that, almost like a lateral shin splints type presentation as well. So perineals, I think, are probably often underlooked and in the context of a cavus foot. But they can definitely be of concern with regards to your management, whether it's a primary cavus or if it's a secondary related to a neuromuscular disorder. A couple special mentions here as well. Here's an example of somebody. This picture here shows one side is a relatively normal foot, and the other side has that peekaboo heel on the right there, which is a more of a cavus manifestation. And we'll see this sometimes in the context of limb length discrepancy. So if I see a patient who has a unilateral cavus foot, this is usually the first place I look. And the reason being is that if you've got one limb shorter than the other, oftentimes you'll supinate your subtalar joint to compensate for it somewhat. And this may be a subconscious thing that your patients are doing. But if you've got any kind of a pelvic dip, or even things like scoliosis and things like that, where you've got some sort of malalignment problem association with the pelvic girdle, or even the hips themselves, oftentimes you will, over time, you'll pronate on one side and you'll supinate on the other just to kind of compensate for that. So it's not really a rotational problem with the limb, it's just really just a function of length. Perineal nerve laceration is another unique condition as well, and this is different than perineal palsies, which tend to be more of a genetic thing like Charcot-Marie tooth. But if you have a direct laceration to a perineal nerve, you can have selective loss of your anterior and lateral compartments. So you're basically going to develop a unilateral cavus foot just because you are overpowering with your posterior muscle group, and particularly the tibialis posterior muscle, which will begin inverting the foot. So this is generally pretty profound. People will have selective loss of the peroneus brevis and longus, and they will really start to, the foot will start to swing in dramatically, and they have to really watch how they're walking. Of course, drop foot is a manifestation of this as well, but drop foot in the context of cavus is a pretty difficult problem to manage and generally needs rear foot arthrodesis. However, some procedures are occasionally appropriate, such as like a posterior tibial transfer. Scoliosis I did mention also earlier too. Any kind of condition that causes pelvic dip or pelvic tilt can manifest itself as a Pes Cavus problem too. So oftentimes, make sure that you're doing an appropriate exam, and it's very important always for any kind of structural problem with the rear foot, whether it's cavus, whether it's a flat foot or posterior tibial tendon dysfunction, even bunions. Get these patients up and walk, because oftentimes their gait pattern reveals a lot larger portion of the story than just what's going on with the feet. Then congenital hip as well. I had a patient who had a real high arch just on one side, and I did what's called Alice's and Galeazzi's test just in the exam chair, which is really an assessment of lower limb length in association with the knee. And what we found is we actually sent her for hip x-rays, and we found that she had a congenitally dislocated hip that she'd been walking on her entire life, and she had no idea. It was not even in the socket. It was sitting directly above, adjacent to the pelvis. I'm going to briefly touch on orthotic management of cavus here, because this is probably the mainstay of our treatment, and most of your cavus patients are going to live in orthotics, generally starting from a younger age. The goal here is to kind of bring the ground up to the foot. We're not so much interested in control of pronatory stress or trying to keep the heel in a neutral stance position with gait. Really, these orthotics are more accommodative in nature, so you're going to want to bring the ground up to the foot and to correct for the deformity. And oftentimes it's a little bit of trial and error. You may not get it right the first time with orthotics for cavus foot, but consider also how flexible is this foot? Is this a rigid cavus foot? Is this somebody who's got a decent amount of flexibility? Is this a neuromuscular problem that's progressive, where they're probably going to have to get a new pair of orthotics on a biannual basis? rigidity really plays into a lot of this because it's going to determine how firm of a device you make. For people that have more of a rigid cavus foot, I'm much more of a fan of using softer material. So we'll use like a leather or EVA top cover, and I'll generally just do like an EVA orthotic, which is pretty durable, and it will hold up pretty well long term, but it's a lot softer. So people, because your patients that have a rigid cavus foot are going to complain that their orthotics are too hard. Or, I had orthotics a few years ago, but they were just, I didn't tolerate them very well. Of course, shoe choice does somewhat play into this as well. And I will tell people too, if you're not using your orthotics, or you need to protect your foot, so make sure you get like even like Crocs shoes, or even like Birkenstocks, or something that's got a bit of an arch to it. Vionic shoes may be appropriate in that instance as well. If it's a flexible cavus foot, we can generally get away with polyethylene, polypropylene, or a more structural type of functional orthotic. But for the most part, you really just want to be accommodative with these and try to bring the ground up to the foot. Customs are the way to go. I don't even bother discussing over-the-counter orthotics with patients, but in certain instances where they may not have insurance coverage for custom orthotics, or they may be unobtainable, there's a couple over-the-counter options that may be appropriate. I did just mention Vionic, so either Vionic shoes or shoe inserts. Those can have a pretty decent arch to them, or in some cases we'll have them get like a pair of Power Steps or a couple of the Superfeed orthotics. And we can actually just do some modification into the office. I call it arts and crafts time, where we just kind of build up a little bit of arch padding and arch fill, just to kind of make it a semi-custom device, even though that felt padding does tend to wear out a bit over time. I don't ever recommend anything like the gel inserts or Dr. Scholl's or any of that stuff. However, I do want to give a shout out to the good Dr. Scholl's kiosks for being one of my favorite referral sources about why people come into our office. And like I said, shoe choice does play into it as well. Bracing, I'm not going to get too much into bracing with cavus foot, because in general, I try to maintain motion wherever appropriate. And I think bracing is more appropriate if you've got some sort of significant ankle pathology, or if you need more aggressive control, or if you have like neuromuscular loss. So obviously, if you have like a drop foot, then an AFO brace is going to be appropriate, even like a posterior leaf spring, just to help give yourself some propulsion during gait. Bracing may be a good option though for perineal pathology in the context of cavus foot, just to be able to support the perineal tendons, limit some motion, and or try to keep that impingement problem from occurring, particularly if you have an enhanced perineal tubercle, or of course people that are not good candidates for surgical management. Bracing is going to be an appropriate solution, is going to be a good way to go. A couple brief considerations here to wrap things up. Perineus longus is very important in the context of cavus. So whether it's a perineal spasm problem that you're having, that perineal tendon that's pulling your first ray down in cavus is oftentimes working overtime. So if you're doing any kind of procedures, or you're doing any kind of aggressive bracing or orthotics, consider the role of perineus longus, and then also maybe educate your patients that you may have some spastic issues associated with this, but these are manageable things that we can do either with ancillary procedures or muscle relaxant medications, things like that as well. Achilles tendon lengthening generally will worsen cavus, just because all you're doing is promoting that increased calcaneal inclination angle. So Achilles lengthenings are rarely indicated for most cavus type procedures, possibly in the case of like a spastic gait type pattern, but I would consider more procedures like a Murphy tendon advancement in that instance, as opposed to doing just a pure TAL. Cavus itself is primarily a sagittal plane deformity, whether it's neuromuscular or not. Multiplanar deformities such as clubfoot, for example, even metaductus, which can sometimes mirror cavus if it's like a forefoot varus type scenario. These are multiplanar deformities, but cavus is primarily just a sagittal plane deformity. So believe it or not, that does actually make it a little bit easier to treat in a lot of instances. And as always, surgery should generally be a last resort for most cavus type procedures. I got cut off a little bit, but you can see that syndromic cavus generally needs more aggressive management. I use the example of Charcot-Marie tooth just because it's one of the more profound cavus and neuromuscular problems that we see. And some of our Charcot-Marie tooth patients do fine long term, but some of them need aggressive things like pantalar fusions in their 20s or 30s. So oftentimes if it's a syndromic cavus, or if it's something that's more of a progressive type deformity, you're going to do a lot better with just aggressive management from the get-go. And it's always, of course, appropriate to have appropriate patient expectations with those. So That was a very quick overview of biomechanics of cavus foot. There's a lot more material I wish I could have dove into today, but well, I'm only allotted half an hour, and I'll see you guys with the next one.